Great. Well, thanks so much, everybody, for being here and taking the time out of your lunch to listen about hyperlipidemia. I'm Rob Allison. I am an associate professor here at WVU School of Medicine, and I'm in the Department of Family and Community Medicine, where I also serve on the core residency faculty for both family medicine and the geriatric fellowship. This was a topic that I got very interested in when these guidelines came out because there was a little hint to it in the American Geriatric Society about a year prior, knowing that these guidelines were coming out. And so I got kind of interested from a more geriatric perspective, but I thought this would be a perfect time with the drop of these guidelines in March of 2026 to talk a little bit more globally about the impact it might have on our clinical practice when we practice full spectrum family medicine. So by the end of today, let's make sure I can advance. Good. Hopefully you guys will all be able to describe the new screening recommendations for dyslipidemia, implement the CPR framework, and understand how to implement the Prevent ASCVD calculator, explain the new LDL-C guidelines and what some of the numbers mean, recognize when to use LP(a) and ApoB, apply the CAC scoring appropriately, and ultimately develop an understanding of dyslipidemia prescribing management. I know there's a lot of objectives. This was 154 pages that went through a lot, and so I just tried to distill it down. By no means am I a lipidologist or a cardiologist, so again, we're all starting to figure this out together. So if there are any questions, please feel free to use the chat or chime in. I'm happy to help or answer the questions the best I can. So the one thing that I really took away in listening to a lot of podcasts and reading a lot of editorials about this is that the writers really wanted to focus away from us using the term bad cholesterol and really start thinking about it as a dyslipidemia syndrome, which encompasses not only the LDL, but a lot of other different blood particles or cholesterol particles, as we'll see moving forward. So right now, 1 in 4 U.S. adults have an LDL that would be treated or would meet clinical criteria for treatment. And when you think about that globally, it's about 25 million more U.S. adults are now going to be statin eligible based under these guidelines. And these guidelines were not just the American College of Cardiology. There were 11 different societies that co-authored these and really tried to update them from the 2018 version. So why does this matter for us? Well, for one thing, we now are starting to look and screen folks at a younger age. So there's a recommendation to start screening everybody at 30 years old. And the recommendation goes up to 79. That's really particular when it comes to the Prevent score, because what we used to use was the pooled cohort equation. And that really only looked at people ages 40 to 75. So we've started this process, or we are going to start looking at people at a younger age, but also continue screening through an older age. So I do want us to just kind of think about that we're capturing a lot more people before or now than we did before. So to start with screening, I really wanted to look at some specific age groups and kind of talk about some of the high-risk categories in these age groups. So I'm sure that many of you heard that there are some recommendations to start screening pediatric patients, and that is correct. So there is a universal recommendation to start screening children between the ages of 9 and 11. And that's because after 11, as they start to become more prepubescent and into puberty, the LDL levels actually go down a little bit. And so they want to capture this age group when the LDLs are most meaningful. And so we weren't really looking at children in the previous guidelines, but we found that there's about 20% of adolescents who have lipid abnormalities. 5% have an LDL-C above 130, and about 1 in 250 children actually have a hereditary condition called familial hypercholesterolemia, and their LDL is greater than 160. So we really want to start identifying these children earlier, because the overarching theme of dyslipidemia management is that the longer we can keep cholesterol low, the better chances we have of preventing atherosclerotic cardiovascular disease in the future. So one thing that caught my eye that actually sparked conversation in our residency was the recommendation to even look at children as young as 2 years old. And that also is accurate. So there's a recommendation to start screening around 2 if that patient has strong family history of premature atherosclerotic heart disease or cardiovascular disease, which means men less than 55 or women less than 65 who suffered a major adverse event. If they have severe hypercholesterolemia, which a family history of severe hypercholesterolemia, which means an LDL greater than 190, or they are known to have or suspected to have familial hypercholesterolemia in the family. Interestingly enough, a family history alone, identifying a very high LDL in these children and having a family history of premature heart disease, actually can help or make the diagnosis. Doesn't have to help, it can be a clinical diagnosis. If you're really suspicious that there might be a homozygous pattern here, then you can proceed with lipid cascade screening. And this is a genetic test and probably best done in conjunction with a cardiologist, in particular a pediatric cardiologist. But just know that you don't need genetic screening if you're suspecting a heterozygous familial hypercholesterolemia patient, specifically a pediatric patient. And it's not to say that these patients need statin therapy. I don't talk about statin therapy in children. Sorry, I don't talk about treating children at the end, but the recommendation for children recognized as high risk is really just lifestyle modifications and dietary modifications. There is some suggestion that statins could be started maybe around 8, maybe around 6, but really, I don't think I would be doing that. I would definitely be getting a pediatric cardiologist on. So when we look at the general adult population, we really should start, there's another recommendation to start screening around 19. And this is kind of bridging that gap between the childhood patients or pediatric patients and the adult patients. I would say that this is probably for a patient that's at higher risk, and then about every 5 years after that. And we really start getting into these universal recommendations or hardline screenings at about 30 years old. You can screen patients more frequently if you suspect that they are at higher risk, but they did mention that you can start screening at 19. The question came up about fasting versus non-fasting. And non-fasting testing is adequate for most adults. Fasting would be preferred if there is a family history of dyslipidemia or premature atherosclerotic cardiovascular disease, or if they're suspected to have a hypertriglyceridemia, because that would be affected with the fasting lab. And here's another thing that I learned. I used to say, well, maybe we'll check your lipids in 3 months. But they're actually suggesting that you can repeat a lipid panel after starting a medication or initiating treatment at about 4 to 12 weeks. And then if you see a response, you can start monitoring them about every 6 to 12 months thereafter. So who are these high-risk patients that we could start screening earlier than 30? Well, you start thinking about folks that have a family history of premature ASCVD, if they themselves are diabetics or overweight or obese. The guidelines really talk about cardiac, kidney, metabolic syndromes. And so that's kind of as it sounds. They have a cardiac condition, a kidney condition, and a metabolic syndrome. They also specifically say you don't have to have CKM, you can just have chronic kidney disease. They also expanded it to talk about immunocompromised patients, in particular HIV patients. If the patient has hypertension, they should be screened early. They're a current tobacco user, which many young people can be. Or if they're at high ethnic risk, which is South Asian, Filipino, those are the two in particular. Or if they're known to have an elevated Lp(a) or ApoB protein, which we'll talk about. And we start to think about risk enhancing factors, which are very similar, but if they develop a systemic chronic inflammatory condition like lupus, RA, or psoriasis, if they have reproductive risk markers, in particular preeclampsia. We talked about Lp(a). They talk about briefly the high sensitivity CRP, but it's not anywhere else in the guidelines. If they do have persistent hypertriglyceridemia greater than 175. So I wanted to make that point because I see plenty of patients who have hypertriglyceridemia, and I'm probably not as aggressive in monitoring them as I should be. Or probably like most of us do, if they have an LDL between 160 and 190, we're probably keeping a closer eye on them and know that they're at higher risk of ASCVD. So who are our very high risk patients? Well, I want to point out that they're terming very high risk almost like we used to use secondary prevention. So they got away from primary and secondary prevention because they want to recognize that those folks that had a coronary event are still very high risk. And so it is someone that has had ACS or acute coronary syndrome within the last 12 months. If they've had a history of an MI or an ischemic stroke, or they have peripheral artery disease, this is really just kind of changing secondary prevention to very high risk. And then they can also have a high risk condition, or they should have a very high risk condition, and that is older adults, diabetics, hypertensives, smokers, chronic kidney disease, heart failure. You can read the list, it goes on and on. But they do specify and stratify, which we'll see in the upcoming slides, this very high risk versus high risk, and how we manage them is different. So they really have had to have an event, and they have had a high risk condition to be considered very high risk. Last, I wanted to talk about the geriatric patients because this paradigm did shift. And now in 2026, we are getting away from the pooled cohort equation. So now we can look at folks older than 75. And we've kind of got away from, or we can start to use more than just LDL guidelines. We can use things like a coronary artery calcium score, or an Lp(a) or an ApoB, to really help reclassify these patients a little bit more and tailor their management a little bit more appropriately. And so I did want to kind of hit on the focus of these guidelines is to talk about functional status over age. And so looking at things like multimorbidity and frailty are really important in this patient population. There's a suggestion that you may not even consider initiating statin therapy if their life expectancy is less than 1 year. There's a likely time to benefit of about 2.5 years after initiating statin therapy for a patient to see benefit. So if that's not in that person's prognosis, then maybe we don't want to initiate statin. Another big thing that they harped on, or they really kind of didn't harp on, but made a point to bring up, is shared decision making. And so statins aren't for everybody, but as we'll see at the end, there's a lot of other different treatment options. So how do we stratify these patients? We use the CPR framework, and that's calculating a 10-year ASCVD risk score, personalizing that patient's individual risk, and then reclassifying them based on some of those personalization markers to really start thinking about what kind of treatment are we doing. So just briefly, the pooled cohort equation that we were using back in 2013 really only looked at 25,000 patients. And really the data was from 1940 to 1980. So think about that, 1940 to 1980. And we were using it just last year to stratify folks in 2025. I don't know about you, but I do things a lot differently now than probably in the 90s or the 80s and so on. So it really didn't match the patients that we were taking care of today. So PREVENT looks at 3.2 million patients. And there, I heard a stat that maybe it was 6.6 million, but everything I read said 3.2. It took race away, but it did add GFR, and it expanded the age range as we talked about. But it also looked at things like, are they diabetic and what is their A1C? What's, if you have their urine microalbumin to creatinine ratio, what is that? And it also looked at these social deprivation indices, and that's based on their zip code. And so depending on where someone lives, they might have a different score, even though they have the other same criteria. But just based on geography, they might have a different PREVENT percent. And for sake of time, but you can have these slides. This is just comparing the pooled cohort equation to PREVENT. One thing that you'll hear in the news a lot is that the percent risk a patient has to have an acute coronary event has decreased. So we used to use numbers like 10% and 20%. The 2026 guidelines and the PREVENT score have cut those in half by about 40 to 50%. And if we went simply by the math, by just saying, well, this person now has a 2% risk when they used to have a 10% risk. That's 17.3 million fewer adults that would meet this primary prevention criteria based on PREVENT. But because we've expanded the age range from 30 to 79, we're capturing about 25 more million adults who would fall into that borderline category. So here's the crux of PREVENT. So someone has a low risk for an ASCVD event if their PREVENT score is less than 3. And therefore, you should be recommending some behavioral modifications or dietary modifications, but lipid-lowering therapy is not really recommended. They are at borderline risk if they are between 3 and less than 5%. And this patient population actually has been recommended as a class 2A recommendation to start moderate intensity statin therapy with the goal of lowering their LDL between 30 and 50%. The intermediate risk are folks whose PREVENT score is between 5 and less than 10%. And they need at least a moderate intensity statin. That's a class 1 recommendation, the highest recommendation the authors can make. And they really suggest higher intensity statins if you're at the closer end of 9 or 8 to 9%, excuse me. And the goal should be lowering their LDL-C by 50%. And lastly, high risk are folks whose score is greater than 10%, and they should be on high intensity statin with an LDL goal of less than 7. If you can't meet those goals, then we can talk about adding on medications. We'll talk about it. But just want you to know that ezetimibe is class 2A recommendation and PCSK9s are class 2B, whereas statins are class 1. So the next part of CPR is personalizing. So let's talk about some LDL treatment targets. So for that very high-risk patient, we talked about having an event and having that high-risk condition. Their LDL target is less than 55. And the authors also talk about non-HDL, which is basically your total cholesterol minus HDL. Some labs are reporting this. I know our lab is, and that should be less than 85. For the folks that have had an event, but just an event, and somehow they didn't have one other extra risk factor, their goal reportedly is 70%, but again, I think most folks in some of the supplemental literature are leaning towards 70 milligrams per deciliter. Most of the editorials are also leaning towards an LDL target of less than 55. Again, if they're post-stroke, same thing, less than 55. If they're diabetic, but again, somehow don't have other high-risk conditions, they're less than 100. And if they do have diabetes, but they have multiple risk factors, then or one or more risk factors, then their target LDL is less than 7. So again, this is just going back to that very high risk, those conditions. We talked a lot about them already, but just wanted to reiterate, it's a major event plus high risk conditions. Folks that are diabetic without an established ASCVD risk score, again, if they are between 40 and 75 and just diabetic, their LDL goal should be less than 100 on a moderate intensity statin, with the goal of lowering their initial LDL between 30 and 50%. If they have multiple risk factors, it's less than 70%. And if they are high risk based on a prevent score, diabetic and prevent greater than 10%, they're also at less than 70. You can see there's some of the approaches may differ with high intensity statins versus adding ezetimibe or a PCSK9 inhibitor, depending on their risk category. So moving on to some of the newer blood tests that were talked about, Lp(a) and ApoB. Lp(a) is a genetic risk, and I kind of think about it as hiding in plain sight because it's always been there, but we just haven't really looked for it. But it is an independent causal contributor to ASCVD. We're not quite sure what to make of it, but there is a strong suggestion. Well, let me back up. Lp(a) is an LDL-like particle that's bound to apoprotein. And apoprotein is just this cluster of all the density particles of LDL, which basically are the irritant cholesterol molecules in our blood. And it is it's inherited in autosomal dominant pattern. And these levels are almost entirely genetic and basically stay the same throughout our lifetime. 1 in 5 people have an elevated Lp(a). So again, we're wondering if this is a link to familial hypercholesterolemia. And it does act as an independent risk factor, contributing to atherosclerotic cardiovascular disease. It doesn't replace LDL or any of the other markers that we use, but it is recommended to test 1 time for everyone. Everyone should get an Lp(a) at 1 time in their life. And here are the scores. If it's less than 125 nanomoles per liter or less than 50 milligrams per deciliter, then they are at low risk. If it's greater than 125, then they do have a 1.4-fold increase in long-term ASCVD events. And if it's greater than 250, they have a 2-fold increase in events. So who should we really be thinking about? Well, again, lots of those high-risk folks. Premature ASCVD, strong family history of heart disease. They have known or suspected familial hypercholesterolemia. They have unexplained residual risk despite controlling their LDL. So their LDL is at goal, but they've already had an event. Or they're falling into the borderline or intermediate category based on prevent, or they have a calcified aortic valve. And so if you hadn't checked an LP little a on these folks, you probably want to, and you want to be a little bit more aggressive. Even if their LDL is at goal and their LP little a is up, I probably would think about maximizing or modifying their statin therapy. Now, for sake of time, there's not much here, except to say that, interestingly, statins can increase LP little a values. So again, the authors aren't saying that we're treating to target for LP little a. We're just saying that it can be a supplemental guidepost when we're starting to when we're starting to personalize our statin management. When it comes to ApoB, this is really an interesting test because this looks, well, let me rephrase. One atherogenic particle will have an ApoB molecule on it. So that's LDL, VLDL, that's very low density lipoproteins, the intermediately dense lipoproteins. And those all get packed in together, and it generates an ApoB number. And so oftentimes, well, not often, about 20% of the time, there's discordance, which means that the ApoB may be elevated. Sorry, let's do it the other way. The discordance may be that the LDL is low. And so you might think, wow, I'm doing a really good job of managing this person's dyslipidemia. But the ApoB might be high. And so that will also suggest that this person is at increased risk of atherosclerotic cardiovascular disease. And you probably do want to maximize their statin therapy or their dyslipidemia therapy. We'll phrase it that way. So when we look at the guidelines, this was just an expanded version of that right chart on the slide before. They're at borderline risk. Their ApoB goal is less than 90 if they're borderline or intermediate. Their ApoB goal, if they're high risk, is less than 70, and their ApoB goal is less than 55 if they're very high risk. And these kind of correspond to the the LDL goals. And I'll go back. When I was looking at this, I might have typed my ApoB goals wrong. So if I do, I'll have a chance to let you know. But we'll stick with these ApoB goals for now. And if there's an update, I'll let you know. I look at them now and I wonder if I didn't just keep copying the same numbers. But I'll let you know. So this is not a firm recommendation just yet from the 2026 guidelines. But we do know that ApoB can be very helpful if someone has those risk-enhancing factors and we still think they're at high risk or they've had an event. You may want to look at ApoB as well, but there's not as strong of a universal recommendation just yet. But they are strongly suggesting that we consider it. So they do suggest that looking at a coronary artery calcium score can be very helpful. So, a coronary artery calcium score is really a direct visualization of the amount of calcium in the coronary arteries. And it kind of goes beyond what a calculator can do, because calculators kind of have these hard ceilings or these kind of finite parameters, where a CAC score can give you a very different look for someone. And so when we use it, we usually want to use it when there's clinical uncertainty about initiating lipid-lowering therapy. Really helpful in that borderline to intermediate risk group from the 10-year prevent score. And you really don't want to use it if a person is already on a statin, because statins increase CAC scores despite slowing plaque progression. You do not want to use it if they have already had an ASCVD event, because there's already coronary artery calcium or plaque in those vessels. Diabetics, really, we should be taking with a grain of salt. Or if they have an LDL that's quite high at 190, because statins are indicated regardless. And so the scores are thus. 0 score is suggested that they have a very low 10-year ASCVD risk score, and you could consider holding statin therapy at that time. You do want to make some exceptions for those with those high-risk features like familial hypercholesterolemia, smokers, or diabetics, as we previously talked about. And then consider repeating every 5 years if they're 40 or older. 1 to 99 is mild disease, and they would recommend moderate intensity statin. 100 to 299, they're clearly statin eligible, and at least a moderate intensity statin, if not high intensity. Greater than 300 should really start to think about subclinical atherosclerosis. And so they're at very high risk of having an event, and they should be on maximum intensity statin therapy with a goal LDL of less than 55. And if it's greater than 1,000, then this really should be considered kind of a dangerous value and probably prompt cardiovascular evaluation with a cardiologist and really getting aggressive with therapy. So this is just a pictogram of when to use it between the borderline and intermediate risks with the scores outlined below. This is just a brief outline on the CPR framework, but for sake of time, we'll kind of move on. So when we reclassify, we talk about types of treatment. Statins will be, at least for the foreseeable future, our first-line medical management options. And so we want to select high-intensity statins with the goal of getting our LDL less than 50% of where it started. And those are atorvastatin, 40 or 80 milligrams, and rosuvastatin, 20 or 40 milligrams. Moderate intensity statins can have about a 30 to 49% expected LDL reduction. And so, again, lower doses of atorvastatin and rosuvastatin, but it introduces simvastatin, pravastatin, and pitavastatin. And again, low intensity I leave on here because just yesterday I saw a gentleman with a previous stent. He is a diabetic, he has chronic kidney disease, and he was on 10 milligrams of pravastatin. Now, he was on a PCSK9 inhibitor, so it's something that I'm really thinking about, like, well, do I need to intensify statin therapy? So I'm working collaboratively with this cardiologist to answer that question because I'm not sure his low-intensity statin is really helping him at all. But again, low-intensity statins, simvastatin 10, pravastatin 10 or 20, and fluvastatin 20 or 40, no indications on the guidelines to ever initiate low-intensity statin. But what else can we use? This is probably my favorite slide, and we're just about done. So ezetimibe has about an 18 to 25% LDL reduction. It's cheap. It's usually pretty well tolerated. It works at the brush border of the gut to kind of reduce cholesterol absorption. And so a really nice option to add and maximize statin therapy. PCSK9 inhibitors have come into vogue, and they have a really impactful measure on LDL between 45 and 64% reduction. And they work, obviously, to inhibit PCSK9, but they also don't have some of the side effects that statins do, although I have heard things like flu-like symptoms and rare injection site reactions, but they're really, really beneficial. The inclisiran is a new medication that's out. It is a twice-a-year injection. Some trials are on their way, and we're not quite sure where it fits right now. Not sure if many people are using it, but it also has a very impactful reduction on LDL. And bempedoic acid as monotherapy, about 20 to 25% reduction, And this is FDA approved for those that are statin intolerant. So just a different oral option for someone that's looking to help lower their LDL without statins involved. In brief, again, just for comparison, we're getting away from the pooled cohort equation and onto the prevent score. We now do have explicit LDL numbers that we're trying to treat to target, and not just reducing by 50%. We really have strong and firm targets for most folks. Lp(a) is a class 1 recommendation. CAC scoring is a class 1 recommendation. ApoB had been mentioned in 2018, but now it really gives us defined goals, although we're not quite sure what to do with them yet. I bet more will be to come. And then we really want to get away from bad cholesterol or the blood cholesterol types of discussions and talk about dyslipidemia as a syndrome that we have multiple different ways of looking at and stratifying a patient to help reduce their ASCVD risk score. So in a whirlwind 35 minutes, we've talked about, hopefully now you can describe the new screening recommendations. You can feel comfortable implementing the CPR framework, classify, personalize, and reclassify. Hopefully you have a little bit of an understanding about the new LDL targets, when to use Lp(a) and ApoB, when to apply the CAC score, and some of the medications that are out there for management. And with that, I thank you for your time.